Hello, welcome to the Resilient Performance Podcast. I'm your host, Doug Kachijian, and today I'm joined by Bill Hartman. Bill is a physical therapist and co-owner of the Men's Health Magazine Top 10 rated and Women's Health Magazine recommended Indianapolis Fitness and Sports Training and IFAST Physical Therapy, where he works with a variety of clients from high-profile professionals to weekend warriors. He is a former columnist for Men's Fitness Magazine, and he has also done a stint as the Men's Health Muscle Guy while being a popular contributor to menshealth.com. And in full disclosure, Bill was one of my mentors in graduate school. I did a clinical internship with him, and he's also become a very close personal friend. One of the most generous and brilliant people I know. It's an honor to have him on the podcast. I asked Bill some really difficult questions, in many cases some unanswerable questions, and even though Bill is one of the better read people I know on a variety of topics, you'll continually hear him say, I don't know, or he would acknowledge that he couldn't say certain things with any kind of authority. So his intellectual honesty is very commendable, and he navigates some very complex topics, I think pretty delicately, but also in a way that's quite insightful. So hope you enjoy listening to Bill as much as I enjoyed talking to him. Bill, thanks so much for joining us. Really appreciate your time. So we're going to get right down into the questions here. I've really enjoyed your blogs and your articles lately, and you recently wrote an article called On Stability, which I think for you is maybe more of a stream of consciousness, but maybe it wasn't intended to be so, but I think it's more of like a conceptual framework that speaks to the spectrum between health, disease, and performance. So can you start by telling us a little bit about, what a complex system is, and then what variability within that system, how that variability speaks to adaptability and survival and those kind of things?
Sure. So I've obviously been studying a lot about complexity theory and things like that, and trying to apply it in the realm that you and I both work in. So from a physical therapy perspective or from a performance training perspective. And complexity theory extends well beyond what you and I do. And so it's providing a framework of thought. And so in regards to what we do and the system that we work with, which is obviously the human system, a lot of perceptions are of the belief that we are somehow complicated. And I would argue that there's a difference between being complicated and being complex, where complicated has a very, very specific cause and effect, whereas in a complex system, that cause and effect is not apparent until the system has to respond to a specific input. And so that's where these concepts of variability come in, is how much does this system have the capacity to change depending on what those inputs are, or what environment you're performing in, or what task you're asking the system to perform. And so depending on the range of variability would be indicative of how much that system can adapt to a specific environment while performing a specific task. And that's kind of what we're dealing with in almost every scenario, whether we're in my purple room doing rehab, or whether we're out in the gym at IFAST doing some level of performance related training. But we have to understand that our adaptability has limits. So if we think about the concepts of like allostasis, so we have multiple systems interacting to maintain this sweet spot of homeostasis, which we would call health. And these systems will have limits. And what we're identifying in our little realm is how this system is responding. And we have certain constraints that we can measure and certain things that we can't. And so we have to rely on our scope of practice, which we're movement people. So we use the movement system as a representation of that system and how variable it is. And so that's the relationship that we have to look at when we're talking about is this client in an adaptable state? And maybe that's why they're presenting with these limitations, whether it be just limitations in movement, or whether they're presenting with pain, or maybe stepping a little bit outside of our scope if we're talking about people that are depressed or anxious. And we see all of that as part of our evaluation even in our scope, we see it, whether we impact it directly or indirectly. That's remains to be seen, and how much can we play, amateur psychologists under certain circumstances when we're dealing with painful situations. But in essence, what we're doing is we're trying to identify is, okay, what range do I have in regards to how much the system can change itself? How can I impact that system to change favorably? And then what are those limits which are preventing the system from being adaptable to the environment in which they're functioning? And that's our problem that we solve. And I mean, that might be a long way to go about it as far as the explanation goes, but I hope I sort of answered your question.
No, definitely. And then you also talk a lot about how these complex systems self-organize. And one of the concepts you use to describe that is that of degrees of freedom. So can you talk a little bit about degrees of freedom and then how manipulating degrees of freedom affects the behavior that a system can display?
Sure. The easiest way to look at degrees of freedom is to look at joint movements and the way the joints are actually supposed to move. Theoretically, we've got, I think it was Zatsiorsky has narrowed it down that we've got 244 degrees of freedom in regards to how we are capable of moving. And then the interaction of those degrees of freedom it creates a larger number of movement possibilities. And so when we're looking at a complex system, that's going to be our display of variability of the movement system. And so that's our measurement of behavior. So if we have a model of what the system should be capable of, we can compare the presentation of a patient's ability to move, and we compare that to like the ultimate number of degrees of freedom. We can say, okay, this system is limited. This system is defending itself against something. So if I can get on a soapbox for just a second, I don't think that humans are machines, and machines have function and dysfunction. I don't think humans actually have dysfunction. I think that they are merely representing how they are responding to whatever the inputs and perceptions that they have, and therefore they're spitting out a behavior. So it's not dysfunctional. It's just that's how they're processing information, and then they're giving us this indication of their response. And so if we can identify degrees of freedom through our examination and, like I said, compare that to what we would consider an ideal situation, that will allow us to move that system towards an optimization of variability, because we don't want too much variability, because then we have compensatory activities that can get people in trouble. But that's how we move forward in our process, is what do I have in this presentation in regards to limitations of variability as represented by the degrees of freedom available, and then where do I need to take them based on my best understanding of how I think that they should move. And so, again, maybe a long explanation, but I hope I answered the question.
No, it makes perfect sense. And I think that what you're talking about even transcends, physical and sports medicine. I remember in the military, so, we would do parachute insertions, parachute training. And obviously the worst case scenario when you're jumping out of a plane is that you have some kind of a malfunction with your parachute. And so we would actually rehearse these emergency procedures before each jump. And the whole point of the emergency procedure was under, the worst possible emergency. So basically there's different clusters of parachute emergencies and things that can go wrong with the chute. But once you identify what that particular pattern is, there was an emergency procedure so that under stress, you didn't have to come up with your own way to resolve that problem. So the idea is, hey, we've done the research in a controlled environment when there are a lot more degrees of freedom and there isn't a lot of stress, and your cognitive ability is a lot more robust, I guess you could say. And then when this emergency happens in the real world, you minimize the degrees of freedom and you just do exactly what you were taught in that procedure. So it's kind of the same thing. That movie Sully came out recently, and I'm sure there was some degree of improvisation involved and just thinking on the fly, and that's kind of the popular narrative. But I know just from being in the aviation world that every time you get in the plane, the pilot's going to look at his checklist before he takes off and lands, no matter how many sorties he or she has done. And if there's an emergency, usually the co-pilot will read the emergency procedure so that, that pilot doesn't have to invent a life-saving procedure on the fly. So the idea is in, high stress, which is really the same as high performance, you minimize the degrees of freedom to accomplish a task, whether it's, executing a physical skill or trying to perform something that's going to save your life or the life of a bunch of passengers. So I think that's really neat. And another thing I want to get into is, I think your model and the things that you discuss speak to the spectrum between health, performance, and disease. And I think, the health and specialization and performance thing, that's kind of clear cut. But this kind of dawned on me, and I don't know if it's something that you thought about or if it was your intent, but I almost see elite performance and those specialized adaptations that are necessary for elite performance in sport, and disease is almost kind of the same manifestation in that, in both cases, this complex system, in this case the human organism, is responding to a real or perceived threat or a very particular set of environmental or genetic constraints in the case of disease. And the system kind of behaves the same way in that, it minimizes those degrees of freedom and it becomes less adaptable and less variable. So Can you speak to that relationship a little bit? And then how would you say that something like pain fits into that construct?
Okay. Yeah. So think about the total number of resources that we have available to us from an adaptable standpoint. But if I shift from this broad, generalized environment where I need, a broad spectrum of variability, or I have a number of resources available to me, but now I provide a much stronger input, or my perception is driven towards a very narrow scope, then I have to shift more resources in one direction. So now I become less variable. I take systems away. So just read like a book like Sapolsky's Zebras, and he talks about, okay, so if I'm under a stressful situation, I don't need reproduction, so that system shuts down. I don't need digestion, so that system's going to shut down. And so what's going to happen is all of my resources are going to be directed into a limited number of subsystems within the system, so I can defend or perform in a very narrow variability type of environment, because what is important at that moment from a survival standpoint is just surviving that moment. So I have to shift my resources in that direction. So when you think about disease, okay, so what happens? Well, I'm going to shut down all of those systems that I don't need. I'm going to enhance those systems that I do need. So, if I get the flu, immune system's going to be on override, right? So that's what's going to make me feel crappy when I have the flu. But you're not hungry at all under those circumstances, and because you're shifting all of your resources towards the defense, and so. From a performance perspective, if I function in a very, very narrow window of demands, then I'm always going to try to limit the complexity of my system to simplify it, because it enhances my ability to generate force. It enhances my ability to generate energy under a specific circumstance. So I have to narrow my performance window to execute. If I have too much dilution of my capabilities, then obviously performance will suffer. And so if I can narrow things, then I can perform at a very high level. So the example I always use is like a 100-meter sprinter. They have very specific energy demands. Very, very little energy is produced outside of the phosphagen system. I have a very narrow scope of demands. I don't need a lot of transverse plane or frontal plane movement. And in fact, any broadening of my movement capabilities in those planes just zaps energy from what I could use to propel myself in a straight line down the track. So, when we examine these people, we're going to see limited variability intentionally to raise the performance standard. And so that just kind of speaks to your comparison between disease and performance, I guess. I don't think we would want to look at them at the same, but it is a narrowing of the variability of the system. It's a reduction in complexity to allow one system or a subset of systems to increase the impact on performance or defense of disease.
Yeah, I think that's a great answer, and it segues very nicely into the next question, which is, and it's the $1 million question. So I don't even know if it's solvable, but in our field, you and I will see highly specialized, highly adapted athletes all the time who come in and they, typically if they're seeing us, it's because they're in pain. So that kind of is going to change the lens through which we evaluate them, and it's going to bias us a little bit, obviously. But we look at these highly adapted athletes, and a lot of times those adaptations are what have made them good and allow them to perform at a high level. But then when we look at them when they're in pain, typically, at least, I think what I do and potentially what you do is we try to find the things that they don't do well from a movement variability standpoint and restore a little bit of that variability just to make them a little slightly more adaptable, but not, take away so much of that specificity and those adaptations that make them good. So I guess my question is, when somebody comes in and you're evaluating that person, particularly when it's a performance athlete or someone who's a little bit more adapted and specialized in what they do, you're always going to see, for the most part, side-to-side asymmetries in joint range of motion. You're going to see certain, physiological patterns. And I guess my question to you is, how do you know when to intervene versus saying, okay, this is what makes that person good, I'm not going to touch it? And again, I think you and I would both be in a much different place if we could answer that question and systematize how to do it and teach it to other people. But I think it's interesting from a conceptual standpoint. So if you could just speak to that a little bit.
Well, I mean, if we're being totally honest, when somebody walks in the door, we really don't know what to do at first, because we just don't know how the system is behaving. So that's what our evaluation process provides us. And that's done under the guise of a model that we've created that's based on our understanding of science and our experiences and what we've measured in the past. And then what do we know about this sport? What needs to be executed? And what you're going to find is that within every physical activity, because we're human and our structural constraints are essentially the same, that's what we're using as our measurement tool, there's going to be aspects of performance that are essential across the board for every human that performs a specific activity. So if we look at a golf swing as an example, there are elements of a golf swing that have to be executed consistently regardless of who that person is. There's going to be a certain type of hip rotation. There's going to be a certain amount of trunk rotation. And that's what golfers work on all the time, is they're trying to create this consistency of certain aspects of the golf swing. And then there's going to be certain aspects of the golf swing that are individualized, right? So these could be compensatory activities under some circumstances. And these are the things that can lead to some pathologies, but it's what makes like a golf swing unique. So look at 10 professional golfers and you watch them swing a club. There's elements that are the same across the board. And then there's elements that are like, where did that come from? So if you know anything about golf, the guy I always give the example of is Jim Furyk's golf swing. He's got one of the goofiest looking golf swings, but there are elements of his swing that are very much like everyone else. And he's got these little quirks that he has somehow developed or evolved as he developed as a golfer that are uniquely his own. Where we impact performance is at these consistencies. And so if we want to talk dynamical systems theory concepts, these would be the attractor states. So these are the things that sort of have to occur, and they're the biggest impacts on performance. As far as the things that fluctuate or these individualizations, now we have to determine, like, okay, how much of that do I really need? And this is where we have to get to know the person, because we can't know these things right off the bat because they're individualized to this person. And so we have to, again, we rely on our measurements and we make safe to fail experiments as we're working with these people. So treatment and performance training is a progression of observation, intervene, and then observe again. So we're measuring, we're doing something to the system, and then we're remeasuring to measure the impact, because again, we're dealing with complexity which does not have a very clear cause and effect. And so that's why we have to experiment. And sometimes we're right and sometimes we're wrong. The goal is to experiment in the safest manner possible. We're not trying to inflict, pain upon people. We're not trying to increase pathology in an effort to improve performance. We want to always protect our patient and our athlete or our client. But we have to perform these experiments because when you're dealing in the realm of complexity, you don't know what the answer is going to be. So again, we have to experiment. We have to see how the system responds, and then we have to again make another adjustment on the back end. When we're dealing with a complex system like humans, their responses are never going to be the same. So I can have the same program for two different people, and they will respond differently. I can perform the same intervention on a patient on one day, and I will have a different response on a different day. That's just how complex systems change, because the system is constantly changing state. It's Newton's second law. It's entropy. We're always different. Every second that we exist, our system is changing. We're starting from a different place. Let me give you another quick example of this. Josh Lindblom is a pitcher for the Pirates that we worked with, and he was talking about how the shape of the pitcher's mound changes with every pitch because you kick dirt away, or the shape of the mound changes where you land, and so every pitch becomes different. And he's constantly making that adjustment. The guys that make the better adjustments can throw consistently. But there's always an element of the repeatability. There's always the attractor states within his throw that he knows that he has to be able to execute. And so the guys that can do that better tend to be the better pitchers. They tend to be healthier. They have a more consistent release point. So again, that release point becomes the attractor. And it's like, do I have enough adaptability and variability within my system that I can consistently hit that one spot? And so if we go back to the beginning of this discussion, I'm a little off track. We have to look at what are the consistencies, what are the attractors, what are the things that have to occur, and that's where we're probably going to impact the system first and foremost. Then we have to take a look at, okay, what are this person's idiosyncrasies? What does he present that he may need? Okay, if I take a little bit of that away, how does he perform? So I measure that, I intervene, and then that's how I make the decision, because you can't know right off the bat. I have to go through this process of the patient becomes their own within subject's design, and we do the same thing with an athlete. We measure, we intervene, and then we react to that intervention.
Yeah, I think that's actually a great answer, and it just speaks to the uncertainty in medicine and how essentially every patient encounter is its own unique experiment. And I think a lot of medical practitioners aren't comfortable acknowledging that uncertainty. We had David Epstein on the last podcast, and he wrote an article recently about how a lot of the interventions performed in medicine, even some of the very invasive ones, aren't really efficacious when compared to a placebo. And I think a lot of that's driven by the fact that, if you're a patient and you're going in to see a physician or, a high-level medical provider, you're going to get treated and to get an answer. And sometimes there might not be an answer. And if you really don't know what's going on, in my opinion, sometimes you're better off not intervening, especially if it's going to be something that's really invasive, that has a very known and tangible potential for harm. And I think that segues nicely into the concept of research in its own right, because knowing you personally, I know that you're a huge consumer of research, but you're also somebody who acknowledges complexity and recognizes the need for self-experimentation and tinkering. And so if we look at the scientific method, right, it's necessarily very reductionist because you're trying to isolate for the effects of a particular variable. Pretty much the entire time that we've been talking, you've been talking about context. And a good, a robust scientific study seeks to minimize the effect of context to get at an answer in a particular type of population. And so we know that evidence-based practice is a huge initiative in medicine, but it's in a lot of ways contingent upon very sort of, in my opinion, oversimplified diagnoses. So in our field, for example, sports medicine, very anatomically driven diagnoses. So you have low back pain, and they might call that something like sacroiliac dysfunction, or you have knee pain, and they call it patellofemoral dysfunction. So they'll basically take what hurts, they'll give the fancy anatomical name and say, that's what you have, as if all those things are the same. And outside of orthopedic trauma, a lot of times those anatomical constructs aren't very insightful, and yet a lot of the research that's done in our field is contingent upon those anatomical constructs. So how do you reconcile your appreciation of complex systems with your desire to adhere to evidence-based practice and scientific methodology, recognizing that the scientific method is somewhat flawed for the very reasons that you just talked about in the last answer?
Well, it comes back to like, so what domain do we function in, and then what is the model that we have created, and we just need to sort of evolve our perspective, expand our model into this complex domain, right? So to get an answer from the research, we have to try to shift the domain that we're functioning into a complicated domain where there is a specific cause and effect, or we try to identify a specific cause and effect. And that's why that it has to be reductionist, that it has to be narrowed, because there are so many potential influences. We have to eliminate influences. Well, we just pay attention to what influence that we've eliminated, and then recognize the fact that what the research is going to show us is one potential outcome, one potential possibility that answers a specific question under specific circumstances. So that doesn't provide us an answer, but it can provide us information that will allow us to make a better decision under the situations that we deal with, which is complexity, where we don't know what the cause and effect is until after we do something. And so maybe we do provide an intervention that results in a very specific outcome that is recognized in the peer-reviewed research. And so you sort of hit the nail on the head there, and now I can make another decision. But again, I have to intervene again, and a lot of these interventions are okay. Trial and error is part of the scientific process. As long as my intervention fits under the guise of good science, doesn't conflict dramatically with peer-reviewed research, and is safe, if I do fail. So I never want to compromise my patient or my athlete's health in an attempt to try to make a change. So again, it's just the difference between understanding the complicated and the complex. And depending on what realm that you function in, so if we just look at the medical field, okay, if I am an orthopedic surgeon and I am repairing an ACL, I would imagine, and I've never done the surgery, but I've seen the surgeries and I know the docs, I would imagine that there's not too many surprises that occur during that surgery, which means that, okay, and I don't want to compare our complexity to a car engine, but it's like a mechanic working on a car engine. There's only so many possibilities that are available to me when I'm working on a car engine as to, okay, where's the problem? What can be fixed? Do I need a replacement part? Whereas when we're dealing in this complex realm, we don't have that opportunity. There are way too many possible inputs. And again, we can use the peer-reviewed research to support some decisions as to how we might intervene, but sometimes you have to be creative. And I always tell my students, don't be creative until it's time to be creative, but there's some times where you have to. So I might need to speak in a certain manner to communicate with a patient, or maybe if I look at my hierarchy of treatment and I'm looking at the impact of subsystems on the whole system, sometimes I need to work my way all the way down where I need to provide a very localized input towards a narrower frame of structure to get the response that I'm looking for. So that's the difference between getting somebody to diaphragmatically breathe, which affects almost every system in your body, to jiggling a joint or poking on some soft tissue or doing whatever you do from a manual therapy perspective to get the appropriate response from the system that you're seeking. And so again, it just comes down to understanding the difference between being in a complex realm and being in a complicated realm, and then how much of that that reductionist information can provide me guidance into how I'm going to deal with the system.
Yeah, I think that's a great answer, and it's kind of similar to the one that David gave last week, where he talked about how, empirical scientific data is the filter through which we can sift through a lot of this information in the clinical world. And to your point, you can use that empirical data to filter, but then when it's time to improvise, it's time to improvise. I think, in a similar vein, if we're talking about medical education, right? So kind of based on the scientific method of reductionism and breaking down these complex systems into subsystems to facilitate learning. I know that, one of the things that frustrated me going through a graduate medical program was you break down this complex system into subsystems without talking very much about the interaction between the systems. And yet I also understand that it makes it much more digestible and manageable to teach this material if you break it down to its components. So, I mean, let's say in an ideal world, if you were able to devise your own medical curriculum, how would you teach it? I mean, would you still do it the same way where we break everything down into the different systems and then try to, figure it out in a clinical internship later on? Or is there a way to better integrate this material initially? So like, when we learn anatomy, we learn, for example, that this muscle attaches to these two different sites on these two different bony landmarks, or this muscle is innervated by a particular nerve. And for the most part, at least in our field, we're not really thinking that way. But at the same time, you still have to know it. So again, this is Bill's school. I mean, where would you go from there?
Honestly, this is what I do when I have a student now, is providing context and an appreciation for having the understanding of how the subsystems interact. So where I think the scholastic programs run into an impasse is they have to provide all this foundational information. It has to be digestible, and so the breaking down of the system into subsystems is essential, because try to learn it all at once. Good luck with that.
Right.
So I have to be able to break it down, but the way it's taught now is meaningless to them as they're learning it. So they tend to start with like gross anatomy and physiology right at the forefront, thinking that, okay, they need this foundational understanding, so then we can talk about how this stuff interacts. Well, I'm totally cool with that, but the working on a cadaver, the appreciation of working on a cadaver is totally lost on these students, because all they're doing is origins and insertions and where these things are, and it's just like rote memorization and then regurgitate on a test, but it's not meaningful. So, for instance, the question I always ask is, okay, so why does the gastroc have two heads that insert into a common tendon in the calcaneus? They don't get that appreciation as to why that might be designed as it is, whereas in school they're just learning, okay, well, it attaches to the femur, it attaches to the calcaneus, blah, 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 and then they have to spit it out on a test. But when you start to understand this, that, okay, so if I have this muscle that attaches in these two places and it's got two heads, well, why does the gastroc have two heads? Well, because it actually impacts the frontal plane of the calcaneal position quite effectively, and so it provides elements of stability and instability as to how we move. Well, then now we've just established an appreciation for design versus just regurgitating a piece of information. So now it's more meaningful. So now that bit of information as to where my origins and insertions, if you want to use those terms, actually lie and why they're there. Now I remember it, because now it's more impactful. It has meaning behind it. And that's where I see, by having a student every semester, that's where I see the limitations in understanding. It's not that they're getting bad information. It's not that they're not intentionally trying to improve the knowledge base of this student. They're just not providing the meaningfulness that is necessary for me to remember this and then apply this in a specific context in the clinic. So, we talk about, just previously about, throwing out like some sort of structural diagnosis. we don't want to ignore the structural diagnosis because that does give us an element as to where the system is attending to this impact on itself. So if I talk to somebody with like, okay, so why doesn't SI hurt? Why does that area decide to hurt? Well, there's something that's impacting the information that's coming from that area. So, but I have to understand in a meaningful way how my biomechanical constraints impact that area that might be causing an increase in variability beyond what I can control or a reduction in variability beyond what I need. And then maybe that's why I'm getting so much information from that area. And so again, that's what they're not getting. I don't think that the design of the curriculum is poor. I just don't think that they're providing a meaningfulness or a context. So if you're going to teach this stuff in segments, in subsystems, as soon as you teach somebody a fact or an anatomical element, immediately apply that into a situation that it becomes meaningful, and now you've got something that carries over into the clinical environment that they can utilize to make better decisions. I don't know. I go back and forth on this. I don't know if it's the school's responsibility to do that or if it's my responsibility as a clinical instructor to do that. But I think that again, from the student's beneficial standpoint, if they could provide some context and provide some meaning, or maybe use like a pathophysiological model when you're teaching these subsystems, then it becomes meaningful as to why these things happen or how they impact the system. And again, allows them to make better clinical decisions.
Yeah, so I mean, essentially, you're speaking to the contextual aspect of learning and even the emotional aspect of learning. I think what you're saying makes perfect sense. Logistically, obviously, it'd be very difficult to, teach some kind of a anatomical fact and then, press a button and immerse somebody in a clinical environment where that clinical fact became more salient. But one thing that, in our military medical training, so Dr. Stephen Rush, who is our medical director, somebody that I plan on having on the podcast in the next few months, he really revamped the way that we were trained medically. And one thing that he did, because again, it's not enough to say, all right, we're going to teach you all this information and it's important because it's going to be on the test. That's not really emotionally going to be the impetus for why you really want to learn something. Right. So what Dr. Rush did was, in our continuing medical education, he would teach us what we needed to know from a protocol standpoint, but for each protocol, he would attach it to a case study. So it didn't require us to actually go out in the field and do hands-on medicine, but it's like when you have that case study and the case study kind of discusses how that information that you're being responsible for learning is applied in a contextual environment, you're like, wow, I really do need to know this. Like this is happening. Someone did this very recently in a life and death situation, and it makes you retain the information so much better than if the only impetus for learning is that you have to retain it for a test. So I think your answer is actually a really good one, and there probably are ways to do it that don't require that much of a change from a resource allocation or a logistical standpoint. And again, going on, along this theme of complexity, in our field, sports physical medicine, a lot of times there seems to be a false dichotomy between pain and biomechanics to the point that a lot of providers don't want to make any definitive statements about how people should move, how they should stand, how they should sit. And I think the fear is probably is that they don't want to embrace certain movement standards because they fear that doing so is judgmental and it can perpetuate fear of particular postures and positions. And we work with people who tend to be in fear of movement as it is, and we don't want to exacerbate that. But if we're talking about complexity, I mean, isn't the movement system just a manifestation of all these different biopsychosocial behaviors that we're talking about anyway? So in other words, what other objective tool do we have within our scope of practice to objectively measure behavior, if not the movement system? And shouldn't that the movement sort of measurements that we take correlate with, neuroimaging and some things that might be a little bit more direct, but in a complex system are seemingly all interrelated anyway?
Well, I mean, our scope of practice limits us immediately to what we can and can't do. But the thing that we need to understand that movement is an emergent property of the system, right? So it is part of this biopsychosocial model. It's behavior. And so that's how we measure behavior. If we're a psychiatrist, we look at, cognitive and emotional situations. and how that system responds to that. And that's where they make their impact. And so we have to use the movement system as our model. And this is where we look at, how much variability does this system have? Do I need to input more variability to allow them to be more adaptable? And maybe that's what alleviates the pain. I don't know that. I mean, look at the potential outputs from a cognitive standpoint or an emotional standpoint. What's the difference between depression, anxiety, and pain? And when we look at neurotags in the brain, they're very, very similar. Well, they're all defensive, protective behaviors. Depression is a downregulation of energy output. So it's conservation of energy to defend against something, whatever that something may be. Anxiety is an increase in energy output in defense of something that I'm perceiving. Variability of the motor system is a defensive or adaptive behavior in defense of something. So it's our scope of practice limits us to that. And like I said, we can play some amateur psychology every once in a while because of the expansion of pain science within our profession and understanding a better understanding of pain science. But the reality is that we're always going to have to default to the motor system because that's our true scope of practice. And that's why biomechanics always matter. But how much do they matter? Well, it matters when it does because of the structure of how we intervene with a complex system. And again, we just don't know what the answers are. So what's our measurement tool? Well, I go back to movement. So how do you move? Okay, what is my model of expectation of how you should be able to move based on the degrees of freedom of a joint, how muscles interact, right? So I just need to continue to grow and expand my model of that, and that provides me a greater understanding of what I'm looking at. Now I know how to intervene, or at least I have an idea of how to intervene. Then I intervene, and then I remeasure. Did I make a favorable change? Okay, if I did, how can I magnify that output? Okay, I didn't make a favorable change, or something bad happened. How do I dampen that? And so that's literally how our treatment needs to progress. And so to say that somebody needs to move a specific way, I don't think that there's one way of anything. I think we need many in the rehab realm. And if you want to look at the difference between performance and rehab, in rehab, I think our first goal is to expand the variability of the system because we don't know what the limiting system may be. So we have to provide a broad enough expansion of variability to address any number of systems. And then the brain sort of sorts out what I need under the appropriate context for that moment. Whereas in the performance realm, we are intentionally stealing variability to raise a level of performance and narrow variability. So all of my resources can be pushed in a limited number of directions. So I raise what the output that is possible. So long story short, biomechanics always matter. It always matters. How much? I don't know, because I don't know what we're talking about in a specific circumstance. I have to have context. I have to have an individual. I have to learn something about them to allow me to make those better decisions. Thinking that you can walk into a room with someone you've never met before, someone you have no rapport with, somebody who might be scared of you, or that they're scared of the situation. There are so many possibilities. I have to get to know this person in some way, shape, or form. I can do that through conversation with my subjective exam. I can do it through my objective exam where I'm assessing the movement system, and then I have to communicate. I can do that verbally. I can do that with expression. I can do that with touch. I can do that with exercise. How I go about that depends on, again, my model, which is always wrong to some degree, but it's the best thing I have to go with, and I constantly try to improve that model. And then I see how my interventions will impact that system. It's an ongoing process. It is never simple. It is occasionally complicated, which makes life really, really easy for us. But in most cases, it's complex, where I have this incredible interaction between systems that I have to discern through my limited scope of evaluation.
Yeah, I think that's a very honest answer, and maybe not always satisfying to some people, but it always depends. on the theme of complexity, we keep talking about integration and context and how all that stuff is really important. But it seems like in a lot of ways, medicine is getting more and more specialized. So in your opinion, what procedures and interventions truly warrant specialization versus those that require more of a global approach?
So I hate to harp on this concept of complexity, but because there's so many possible influences, if you function in that realm, we have to maintain a generalist foundation of understanding. Then we have to consider that, okay, well, I do need a certain number of tools because how many ways can I impact this system, right? So from a global perspective, and again, if you start with my thought process right now is that, okay, you think about the hierarchy of a human. Okay, what's step one? Well, I got to get enough air because usually bad things happen when you don't breathe at all. So I have to determine whether I have enough variability in the way that I breathe. So again, it's not that there's one way, it's that I should be able to breathe in any number of positions and movements and activities to supply enough oxygen to my brain. Well, does this patient have that variability? Well, guess what? If they don't have enough variability in the ways that they breathe, their movement tends to be limited because the brain will not let you go where it cannot get enough air. Otherwise, you'll see people holding their breath, or you'll hear big grunts when they move because they had to valsalva to overcome the inability to move air under certain conditions. So again, that's at the top of my hierarchy. But to communicate with this system, I might need to move down the hierarchy. Maybe I have to touch their skin, or I have to move their skin around, or maybe I have to wiggle a joint. So my afferents is coming from a physically deeper structure where I might have to impact a mechanoreceptor to make the appropriate communication. But understand that it's done in a hierarchy. Every complex system develops a hierarchy because the high levels of the system always support the low levels. So my respiration, sure, it impacts my movement. It impacts my nervous system by altering any number of ways, but influencing pH of the bloodstream. But if I don't respire effectively, then all of my cells don't get enough oxygen. So then I become hypoxic, and then that feeds back to the nervous system. And then I get an output of motor behavior. So again, I have to start thinking in how does this hierarchy work for the system? And then what is my hierarchy of treatment? How specialized do I need to be depends on what environment I work in. So yesterday, I had a client come in with a diagnosis of a frozen shoulder, and through examination, I would wholeheartedly agree with the signs and symptoms that we would associate with that diagnosis. It was very clear. And you know the type of environment that I work in, where I don't see people frequently. I work on a cash-based business, and so I turned him away and I sent him to somebody that works in a different environment. And so if I work in my specific environment, the way that I try to impact the system is through specific levels of this hierarchy, whereas someone else that needs a different type of stimulus of, say, higher frequency of treatment, and again, just a different realm in which they work in, I need to push them towards what their specific needs are based on how their system is responding. So they might need more local work that I just don't do anymore because of the realm that I work in. So I hope I'm making a point, I guess, in regards to what you've asked. Did I hit on it at all? As far as
and I think you answered the question on a micro level, and I should have posed my question a little bit more clearly. I think that on a macro level, if we're talking about different health professions, so not within the same profession, I think a lot of times the distinctions that are made between different professions, whether it's in health or fitness, are kind of arbitrary, and they're based more on political and monetary incentives, because obviously there's a huge incentive to sort of make what you do very unique from a marketing standpoint, and trying to establish your particular political turf. But I think a lot of times that's to the detriment of a patient, right? Because you've seen this all the time, as I've seen, where you probably have treated a patient where they come in and they've they've already been to other physical therapists. They've been to primary care physicians. They've been to acupuncturists and chiropractors and personal trainers and their yoga teacher. And like everyone's giving them a different answer. And obviously there might not be an answer. Maybe all those answers are to some degree right in a complex system, but everyone's looking at, these patients through their own very specialized filter when, a lot of times like does like yoga or chiropractic care or acupuncture or even physical therapy, does it really warrant a very unique field where we're not talking about like an orthopedic surgeon who I want to go to the orthopedic surgeon who's done 10,000 ACL repairs if I tear my ACL. I think that requires a much higher level of specialization than, say, what we see in the movement world. But to me, it's just kind of strange that there's like, I don't even know how many different types of movement professionals when, you could probably get a little bit more global initially. And then depending on, like you said, your specialized needs, find somebody who's, I guess, sees things through a very particular lens. But it gets a little bit ridiculous at times. I mean, have you encountered that in the clinic where you've seen people who've just been run through the mill because no one took that global approach?
Yeah, well, again, it's like, okay, what is the model that you're working from? So, if I'm a yoga instructor and all I study is yoga, and I don't have any understanding of the impact of the subsystems of the system, that in some circumstances you hit the ball out of the park because maybe certain types of people that have a specific issue are drawn to you under those circumstances, but how do you handle the people that don't? And if you're the one trick pony because of your specialization, from a business standpoint and from a marketing standpoint, what do they tell you? Specialize, because it's better to get 1,000 people with one problem than to try to get one person with 1,000 different problems. So again, I can sort of understand it from the business model perspective, but as far as impacting movement, I don't get it. It's a limited scope of understanding. It's a limited model, and it makes us look good, I guess. For you and I, because of how we work, because we do have that much broader understanding, and when we can see how many other aspects of inputs affect the system, so it lends us to a greater opportunity for success, and I don't think that we need all this specialization in regards to all of these different types of practitioners that take one small aspect of movement and then try to magnify that as the end all be all. I think it's a disservice to a complex system by only looking at one aspect of it. From a medical model perspective, obviously we need specialized medical care because when we do narrow down that, hey, it's this one specific system that we're really, really dealing with, now I need to get in depth with that specialization. For what we do from a movement perspective and from our scope of practice and how we evaluate the system, we need a broader scope.
Yeah, I think that's a great answer. And, I collaborate with other movement providers all the time, many of those from the field that we just talked about. And if you watched, what those people do and what we do, and if you take the common denominators and you didn't know this person was a physical therapist, this person's a yoga instructor, this person's a chiropractor, this person's a primary care physician, and you just watch what they did, I think the successful people are kind of all doing very similar things. So the titles can be misleading at times because I think that the people who, recognize the importance of integration are doing it, and they don't see things through those very specialized lenses and those silos. But obviously, professional bodies for political reasons try to overemphasize their uniqueness, I think, again, to the detriment of the patient. So
right.
last question, and I think it's a good way to summarize everything. You've been very unapologetic about the fact that you're a tinkerer, you embrace the whole N=1 concept, and during the last year, you've tinkered with yourself and made some pretty impressive physical changes. So can you talk about your physical transformation and how you went about achieving it? Because it's super impressive for the people who don't know about it.
Man, it's not that big a deal.
It kind of is, but anyway, we have the photos to prove it. We'll put that on the site later. But anyway, go ahead.
recognizing the impact of certain aspects of my lifestyle on my health and behaviors and all of those things, and then trying to reclaim youth at the age of 50 and trying to have a goal. It was like, okay, so what things can I do that would be something to drive interest and have a challenge, and then ultimately impact some of my health concerns. And I'm not a sick person. I just I want to have a high quality of life. I want to live as long as I possibly can and remain capable of taking care of myself. So I actually a little over a year ago, I was communicating with Dr. Mike Russell, who we both know, and if there's one guy that I trust from a nutritional standpoint, he's my guy. And so one of the things that I always recommend to people, no matter what your understanding or capabilities are in any specific aspect of what you do, is to hire a coach for the objectivity purposes. So I hired him to guide my nutrition in an effort to reach a ridiculously low body fat percentage. So I had roughly 5 months and change where I'd already started. I was already into this thing about a month and dropped about 10 pounds. I was about 206 when I started. Pounds, and I said, Mike, let's really go after this thing. If I threw caution to the wind, I said, I don't care what my end body weight is. I just want to see how lean I can get. Also the understanding that smaller dogs live longer. And so, at 206, I wasn't like overly fat or anything like that, but I wasn't in the best shape of my life. And, I wanted to see what I was actually capable of. And then I was also monitoring blood work at the same time, just to see how it would impact my blood work. Because I genetically speaking, my dad had a widowmaker heart attack when he was 52. I'm going to be 50. I want to make sure that, I can impact whatever genetics that I do have favorably as much as I can. I want to control systemic inflammation. I want to minimize the, rusting from the inside out kind of a thing. And then I want to remain cognitively capable. And so all of these things were in the back of my head as I'm doing this. So, from a training perspective, I'm trying to manage how much intensive stress that I impose on myself, and I've reduced that dramatically. I think carrying around a lot of unnecessary muscle mass is actually a stressor. You think about like the sympathetic output that it requires for you to build so much muscle and to carry it around on a regular basis, and then just the maintenance of that requires high levels of blood sugar, which can impact health, and again the sympathetic drive that's required inhibits your ability to manage systemic inflammation. Inflammation being the influencer of every decent disease that kills us all, from heart disease to cancer to whatever. And so again, I was just trying to impact all these things at the same time with the outward representation of, okay, let's get like crazy lean. And so that's essentially what I did. So in going from 4 intensive workouts a week to 2, increasing my volume of low level activity, trying to improve my movement capabilities within the limitations I do have. So I have 2 total hips, which you can't really tell unless I tell you that. And it doesn't really impact anything that I do on a regular basis. I feel no pain or limitation in that regard. I've got some other boo-boos and stuff that I have to work around from a chronic pain perspective, just because I've been around for 50 years and I played college football and threw javelin and then bodybuilded and powerlifted for the last 30 years. So again, there's some wear and tear there that I can't do anything about, but I try to manage that. And so I take all these things into consideration. And we designed a plan. We executed it for about 5 months, and then it culminated with a photo shoot for Men's Health magazine, which was kind of cool. So I checked that one off the bucket list, which was kind of neat. The childhood dream of being in the muscle mags when you're 17 or 18 in high school. So I finally got to do that. And then looking at the blood work, I was very successful. My markers of systemic inflammation are practically non-existent. My hormone levels are great. My sleep has improved dramatically. So it's impacting everything that I'm trying to do from a health perspective, and I've maintained that for the last year after hitting the single digit body fat goals. So it's been kind of neat. It's like I said, I don't think it's that big a deal, but I was able to do the experiment on myself. Will it work for everybody else the same way? Probably not. But again, there are elements that probably will. But that's basically the gist of the transformation, if you will.
Well, I think it's impressive because it shows what's possible. And I mean, knowing you personally and having been your student, I know how hard you work. So you work a lot of hours, and you also have a decent social life. So you only have so much time to train. And so you weren't even training a crazy amount of time when you were making this transformation, right?
No. Like I said, I think at the most intensive part, there was probably like a 3 or 4 week period there where I was doing maybe 3 intensive training sessions per week, and those would be like strength related sessions, and so those were my high stress days, and then I would mix in 2 or 3 very, very low stress days. So the people that argue that the only way to get lean is with high intensive strength training and then high intensity intervals. If you look at the impact from a nervous system perspective and from your ability to control a lot of the other systems in your body, some people can handle it, some people can't. Clearly, my physiology does not allow me to do so. And so I just basically kind of figured out who I was and how I can impact my system the most. And I relied heavily on the nutrition side, which I wholeheartedly agree with from the get-go. I don't think there's any way to out-train a crappy nutrition program. Tried to minimize fluctuations in blood sugar, and then the output or the impact was a massive reduction in body fat. So I went from 206 in the day of the photo shoot. I was 169, and now I fluctuate between like 175 and 178, depending on whether I have Mexican food once a week or not.
Okay.
So take it for what it's worth. It's one representation of what is possible. I don't think the rules would change too much. It's just how you interpret the rules and then apply it to yourself.
All right, very cool. Well, we're coming up on an hour here. So in closing, Can you talk about how people can learn more about you, and then maybe what you have planned for the future as far as what kind of things are exciting you?
Sure. You can find me at billhartman.net. Recently sort of re-energized the blog a little bit. So I've been putting out some stuff, which we've kind of talked about today. And obviously I'm somewhere on Facebook under my name. I think it's Bill Hartman _net, maybe. I can't remember. I don't think about those things. If you're in need of some direct examination, treatment, or training, obviously you can find me in Indianapolis, Indiana at IFAST, Indianapolis Fitness and Sports Training, with my partner in crime, Mike Robertson, who is quite prolific himself. And so those would be the primary areas where you want to try to track me down, and happy to help in any way that I can. Let's see, for the future, I think we've got IFAST University, which is kind of a big deal as far as providing some of these foundational concepts for people to understand, improve their working models, so that they're much more successful. We're trying to eliminate some guesswork and provide a level of understanding that allow the trainers and therapists and other professionals that may benefit from the information of how they can improve their interventions, how they communicate, how they can improve their business models. So all those things are covered at IFAST-U. So that's actually a really big deal. That's growing by leaps and bounds. And so you probably want to get in there now before we get too full. And then I think, eventually I think we need to get out on the road a little bit and share some of our information as well through seminars and courses. So I think we're moving in that direction. that's pretty much what we're doing.
All right, well, that sounds awesome. We look forward to sharing that information, and thanks again for your time today, Bill.
Thanks for having me, Doug. Good to talk to you, buddy.
Take care. Bye.